Lysosomal storage disorders, Part 2, Module 4, Lecture 3, and the genetic theory. Sanfillipo, or MPS III, is the second of the most common lysosomal storage disorders. It occurs in about 1 in 50,000 individuals. All forms are autosomal recessive in inheritance, and there's currently no treatment or enzyme replacement. Sanfillipo type A is characterized by hepatosplenomegaly, progressive coarsening of facial features, progressive mental retardation, epitope movements, but no skeletal features, so no contractures. There's more CNS and less systemic. When looking at all the different lysosomal storage disorders, I like to start with hurlers, which pretty much affect all the body systems equally. You have cognitive delays, hepatosplenomegaly, joints, cornea. Hunters doesn't affect the cornea. And Sanfillipo doesn't affect the joints, but has more severe hepatosplenomegaly. Fabry Disease is another lysosomal storage disorder, the next most common, occurring about 1 in 40,000. Males usually start showing signs of this disorder in early adolescence, earlier if you know what you're looking for. Early symptoms include the inability to sweat, something called keratopathy, pain in the hands and feet or acroparesthesias, and angiokeratoma. Fabry disease is inherited in an X-linked fashion, but I don't like to use the word X-linked recessive because heterozygous females can have symptoms that range from mild to severe. So females that have one copy of this gene that's not functioning have a 50% chance of passing this on to their offspring. If it's a male, they have no functioning copy of the gene. If it's a female, she gets a functional copy hypothetically from her father. In Fabry disease, it's caused by the deficiency of the enzyme alpha-galactosidase A, and this results in the deposition of global transceramide in the vascular endothelium. The glycolipid deposits in the endothelial cells of smooth muscle result in obstruction of small vessels, which causes ischemia. Angiokeratomas is a non-blanching skin rash. As stated, other features include inability to sweat and pain in the hands and feet. Cardiac abnormalities include left ventricular hypertrophy, mitral valve prolapse, and or regurgitation, and premature stroke. Ocular finding include whorl keratopathy. This can be seen in females. And this can actually, here's the whorl keratopathy, this can be used by the ophthalmologist to diagnose females. So many of women with one copy that's not functional for this enzyme have symptoms as severe as males, and this has to do with non-random axon activation. Axon activation occurs early in development, and so if you think about it, there's a small pocket of cells in the brain that is not that has the X with the normal function for alpha-galactosidase is inactivated, and so the X that's active doesn't have a functional copy of this enzyme. Therefore, we have accumulation of the global transceramide that's obstructing the small vessel, and in the brain that causes a stroke, and in the heart that causes a heart attack. Renal failure usually occurs later in females than their later counterparts, and the reason for this is you only need a quarter of one kidney to have normal kidney function, but early strokes and heart disease is more common in females. So the microvascular disease, as I stated, is the main problem. It includes the microvasculature of the kidney, heart, and brain, and these are the structures that have the smallest capillaries. This results in death of the tissue because of ischemia. Cardiovascular disease is the most common cause of death in both males and females. It was probably not recognized in males because they had the renal disease and then they might have had a heart attack, and it was always assumed to be related to the renal disease, but it is actually the same disease process occurring in both things. The next disease is Gaucher's disease. As we stated, it's the most common of the lysosomal storage diseases. It's inherited in autosomal recessive, and it's due to the enzyme glucosidase. It's actually a common Jewish disease. The population prevalence in the Ashkenazi Jewish population is 1 in 500 affected. Features include bone disease, which results in early fractures, hepatosplenomegaly, here's this severe abdominal distension, anemia, thrombocytopenia. Bone marrow cells can show these things called Kupffer cells. It looks like crinkled newspaper, and this is one of the earliest signs of this disease. Bruising and bleeding, lung disease, and growth retardation. This is just a historical timeline of Gaucher's disease. This is, again, the most common. It usually presents for medical complications in adulthood, although symptoms are far earlier than that. But the first case was described in 1882. The accumulation of glucocerebrosidase was recognized in 1932, whereas the lysosome wasn't even known until 1955. The enzyme deficiency was recognized in 1965, and it was actually one of the first genes sequenced. So the glucocerebrosidase gene was sequenced in 1985, and enzyme replacement was begun in 1991, but then changed to recombinant enzyme in 1994. So we have over 30 years experience, over 20 years experience in enzyme replacement with this disorder. So, looking at the results of enzyme replacement, as far as the anemia and thrombocytopenia, 2.5 gram per deciliter increase in hemoglobin in anemic patients after 9 months, and a 50% increase in the platelets of patients with thrombocytopenia, assuming that they still have a spleen. One of the earlier treatments for Gaucher's disease was removal of the spleen because of splenomegaly. Visceral reduction, 20% decrease in the liver volume after 9 months, and 45% decrease in the splenic volume. So enzyme replacement preventing, making splenectomy unnecessary. Another option that's being looked at in a lot of these lysosomal storage diseases is something known as a substrate reducer. And the substrate reducers inhibit the synthesis of the product. In the case of Gaucher's disease, glucocerebrosidase, the hope is that there's enough enzyme to take care, when there's less, to take care of what's left. These are oral medications, and they're actually now first-line therapy for the treatment of Gaucher's disease. Studies have shown similar results to the reduction in the enlargement of the spleen and liver and anemia, as opposed to the IV treatments which require IV therapy every other week. The next lysosomal storage disorder I'd like to discuss is Pompe's disease. And this classically occurs in children with failure to thrive, severe hypotonia resulting in feeding problems, sucking and swallowing for weight gain, hepatomegaly and macroglossia, so low muscle tone or a big tongue is not a good combination. Cardiomegaly is a significant complication and a cause of their early death. Marked elevation of an enzyme creatine kinase, as well as liver enzymes including aspartate aminotransferase and alanine aminotransferase, or ALT. This disease can also occasionally occur in young adults, adolescents, and adults. Characterized by progressive weakening of skeletal muscles, difficulty walking and climbing stairs because of this muscle weakness, respiratory insufficiency, sleep apnea, eventually requiring mechanical ventilation, feeding and swallowing difficulties, again, elevated CK and the liver enzymes. What happens in Pompe's disease is healthy microfibrils are replaced by glycogen. And this glycogen deposits result in low muscle tone. The most important muscle in our body is our heart. So while there's proximal muscle weakness, the cardiomyopathy is one of the leading causes of morbidity and mortality, especially in the pediatric population. And this is unfortunately the natural history of Pompe's disease. By 10 months of age in the infantile form, most of these patients are dead. They actually did a study looking at enzyme replacement, And it was a controlled study, and here are the kids getting the enzymes, and here's the kids not. This actually was stopped after 3 months. This medication, Enzyme, was the fastest ever approved FDA medication because of the there are very few studies that show this much benefit. There's such a difference between getting the enzyme and not getting the enzyme. Unfortunately, many of the patients show resistance to this medication over time, but it's certainly been a great success. Niemann-Pick, moving on to the next lysosomal storage disease. It's caused, Niemann-Pick type A is caused by acid sphingomyelinase deficiency. Again, it's recessive. It's another disorder more common in Ashkenazi Jewish population. 1 in 100 individuals with Ashkenazi Jewish descent are a carrier of this. Clinical features include very significant hepatosplenomegaly, developmental delay. They can have a cherry red macula, interstitial lung disease because of sphingomyelin and pulmonary macrophages result in frequent respiratory infections. Niemann-Pick type C is a lipid storage disease that can present during childhood or adulthood. Classically occurs in mid to late childhood. During infancy, it can result in ascites, which is fluid in the abdomen. MRI is normal to late stages. Symptoms include clumsiness, gait disturbances, impaired vertical gaze, cognitive impairment, dystonia, and seizures. Tay Sachs, fortunately, is the least common of the lysosomal storage diseases. It affects the gangliosidosis, the inability to break down gangliosides in the lysosome, so it only really affects the CNS. Babies are normal at birth, but by 6 months the development slows. They show loss of peripheral vision, and by age 2, recurrent seizures, diminished mental functioning, loss of coordination, inability to swallow, and breathing difficulties. So unlike the other lysosomal storage diseases, it doesn't affect the liver, the spleen, the heart, the muscles. It only affects the brain. Here is the cherry red spot, and this is because of the accumulation of lipids around the ganglion. It's caused by mutation of the enzyme hexosaminidase A. It's a autosomal recessive in the carrier frequency in Ashkenazi Jewish population. Again, this is another Jewish genetic disease. Is 1 in 30. Having said that, carrier screening has been being done in the Jewish population for over 3 generations. To actually see a child with Tay Sachs, they probably aren't Jewish. So the carrier frequency in the general population is 1 in 300. So to actually diagnose a child with Tay Sachs, they're probably less likely to be Jewish. So we're going to review a little video here.
Hello, this is Trevor Cook, and you're watching the Romance Doctor. Now, every one of us has had trouble memorizing the massive amount of information in lysosomal storage disease. So I'm going to show you a quick and easy pattern that is guaranteed to get you to the point you need so you can move on to the next question. So, what is the pattern? The pattern is the first valve. So, in the example of Tay Sachs, the first valve is an A. And what is the enzyme deficiency? Hex A. What's the accumulation? The gangliosides. See? A. It all matches up. What's the presentation? A cherry red macula. And presentation in the brain. It also has world signs. For Niemann-Pick, I have it. It's sphingomyelin and sphingomyelin. And what's the presentation of Niemann-Pick? It's organ. And also you can present with cherry red macula, so don't forget to involve that in the differential. So these big organs like hepatosplenomegaly. And what does it have on microscopy? It has zebra bodies with an eye. So for Gaucher, it's the U. So glucosidase are the first ones with U. And glucosidase also tick. They have the same big organs as Niemann tick, but this time we're calling them huge organs. Huge. And what's the difference between this and the other one? You live after 2 to 3 years. So that's really nice. And it also presents with macrophages that look like crunched up paper. This is shrimp cook, and you're watching the run background.
Finally, a question. A 42-year-old female is complaining of fatigue. She was noted to be anemic with a hemoglobin of 9. Normal is over 12. On physical exam, she has an enlarged spleen and liver hepatosplenomegaly. Enzyme analysis indicates the deficiency of the enzyme glucose reversidase. What is the diagnosis? A. Hurler syndrome, B. Tay Sachs, C. Fabry, D. Hunter's, or E. Gaucher. This concludes this lesson.